So without further ado, I will introduce the first speaker, who is Dr. Shaheenah Dawood. And actually, I think she needs no introduction. She's quite well known here in Singapore. So people who have attended APBCS, who have attended IBRCA will actually know her. She's a very good speaker. She's a consultant medical oncologist at Mediclinic City Hospital in Dubai, UAE. She trained in medical oncology at McGill University in Canada. She subspecialized in breast cancer management at the MD Anderson Cancer Center in USA. She has a Master of Public Health degree from the Harvard School of Public Health, and she is very well published. So she's going to tell us today about BRCA testing, old story and new opportunities.
All right. So thank you for the invitation to come and talk about BRCA testing, old stories and new opportunities. Let me tell you what I've learned since I came to Singapore a couple of days ago. So first, the weather is beautiful outside. Two, there are many hotels around here. So that's why I think a lot of your guests have probably gotten lost, or they're stuck at ESMO Asia, which I think has been fantabulous this year. And you know, three, I think we've had an awesome crowd that really wants to learn about something that's very, very important. And I don't know if you came to the PARP talk that we had yesterday at ESMO Asia, but it really was very well attended, really reflecting the fact that a lot of people now want to try and incorporate this into their clinical management because it's become that important. But let's start going back in history. The story begins in the 1990s when Mary Claire King actually first discovered the whole concept of the BRCA gene, which was on the 17q21 chromosome, that was essentially associated with a higher risk of developing a number of BRCA-associated malignancies, such as breast, prostate, pancreatic, and ovarian cancer. And the reason why this detection or testing of BRCA gene mattered in patients who were at these higher risks was because we knew that if you had a mutation in either BRCA1 or BRCA2, you had a higher risk of developing breast cancer and ovarian cancer, and these risks in fact increased over time. Now, when I have a patient that has breast cancer, and I don't do screening, but as a medical oncologist, I'm seeing patients who come to my clinic already diagnosed with some malignancy or the other, and if they've got breast cancer that are young and I've tested them and they actually turn out to be positive for a BRCA1 or a BRCA2, I immediately tell them that they're at a 70% lifetime risk of developing cancer of the other breast. They're at a 50% lifetime risk of developing ovarian cancer, which increases exponentially by the time they're aged 40. And you have to put parameters in line or in place to be able to screen these women going forward. So it does become an important tool to be able to screen your patients who are already diagnosed with cancer, as well as you have to be able to counsel them in order to be able to test their family members, because they also have a 50% probability of carrying that gene. And we do realize that since the introduction of the whole concept of BRCA testing, there's been a huge upsurge in terms of testing for BRCA. We also know that the models that we have here, such as the BRCA Pro model, that it's a simple program online. You have a person that comes into your clinic and you try and compute their risk of or their probability of actually having the BRCA mutation, and you can see where testing is not being recommended. So I think the mic is working now. It wasn't working before, right? So and in people where the testing is not recommended, studies have actually shown that you could actually miss almost 28% of those people carrying the gene. So we don't have a perfect model that can actually accurately predict for who does or does not have that particular BRCA mutation. Why is BRCA mutation important for medical oncologists? It's because we now understand that patients with BRCA mutations could potentially actually benefit from using a PARP inhibitor. So you have a target with a drug that can attack that particular target. Why is that so? So this slide basically gives you a very quick mechanism of action. You have your DNA that could develop single-strand breaks, and in order to repair the single-strand breaks, you need base excision repair, and for that you need the PARP enzyme. You can also have double strand breaks in your DNA, and that is usually repaired by homologous recombination. And we know in patients who've got a BRCA mutation, this doesn't exist. It actually is deficient in these patients. So in patients who have a BRCA mutation, where they do have a non-functioning homologous recombination mechanism, you could actually treat them with a PARP inhibitor, so you're inhibiting that PARP enzyme, and as a result, that cancer cell will eventually die. And so as a result of this hypothesis, PARP inhibitors have been extensively investigated. This was one of the first papers that came out way back in the early 2000s, where we saw preclinically that if you attacked a cancer cell line that was BRCA deficient and you attacked it with a PARP inhibitor, you could see very nicely that these tumors actually responded very, very well. And this was a phase 1 clinical trial that actually looked at taking a variety of different patients with BRCA mutation positive disease. This was a patient with ovarian cancer that was treated with a PARP inhibitor, and you can see this was at baseline. At 4 months, the tumor had decreased in size. This was another patient that was also an ovarian cancer patient at baseline, and after being treated with a PARP inhibitor, you can see it's almost disappeared. So as such, we then went on to test PARP inhibitors in a number of different malignancies. And the 3 most important malignancies that we'll discuss today includes ovarian cancer, pancreatic cancer, and breast cancer. We're also going to talk about prostate cancer, but a little later during the talk. Now, why was it important to actually look at PARP inhibitors in patients with ovarian cancers? Well, almost 13% of patients with ovarian cancers, in fact, have BRCA mutations. And not only do they have BRCA mutations, they have a whole spectrum of different mutations that attack the homologous recombination pathway. And these patients almost constitute almost about 50% of patients with ovarian cancer. Now, there's a lot of data out there that's looking at patients with ovarian cancer and treating them with PARP inhibitors, but the most important trial in my mind is a SOLO-1 trial. This is the only trial I'm actually going to show you for ovarian cancer, and I'm going to look at some of the other data later on. But the SOLO-1 trial took patients with ovarian cancer who had BRCA mutation positive disease, either BRCA1 or BRCA2. These patients had either a partial or complete response to their chemotherapy in the induction phase, and then in the maintenance phase they were randomized to either receive olaparib or they were to receive placebo. And you can see spectacular Kaplan-Meier curves, very early separation of the Kaplan-Meier curves, which translated into a median progression-free survival of 13.8 months in the placebo arm, not reached in the olaparib arm, translating into an almost 70% reduction in the risk of progression of disease. And you can see in the subgroup analysis, every single cohort of patient actually benefited from receiving olaparib, including those hard to treat high-risk groups, such as those that had partial response, or those that had residual disease at post-debulking of their cancer. So again, all subgroups actually benefited. What about breast cancer? In breast cancer, there was a proof of concept trial that was published way back in 2010 by Andrew Tutt's group. And what they essentially showed was that in patients with BRCA1 or BRCA2 mutations, if you subjected them, these were heavily pretreated patients, if you subjected them to a PARP inhibitor, more than 3 lines of therapy failure, you did have some nice responses. This was one example of a patient with bilateral IBC triple negative with a BRCA1 mutation. Look at that tumor. It was really horrible pre-PARP inhibitor, and post-PARP inhibitor, a nice response. This was a patient with the same patient with lung metastases as well, and you can see 18 months on, the patient is still responding to that PARP inhibitor. So this spurred 2 important clinical trials that actually looked at PARP inhibitors in patients with BRCA1 or BRCA2 germline mutations, in patients who had been pretreated with either first-line chemotherapy, or if they were triple neg, or endocrine therapy post their having progressed on multiple lines of endocrine therapy therapy if they had hormone receptor positive or plus HER2 negative metastatic breast cancer. And you can see whether you looked at the Olympiad trial that looked at olaparib versus physician choice of chemotherapy, or the EMBRACA trial that looked at talazoparib versus physician choice of chemotherapy, you can see there's a nice separation in the Kaplan-Meier curves with about a 4-month improvement in the progression-free survival. So again, 2 important positive trials. What about pancreatic cancer? Now, all of you know that patients with pancreatic cancers, metastatic, have abysmal outcomes. Their prognosis is really, really bad, with an overall survival ranging from anywhere from 6 to 12 months, even in the best setting. But now we've come to learn that there are targets that one could potentially use in patients with pancreatic cancer. Very interesting poster that was presented at ASCO this year that took 1,676 patients with advanced metastatic pancreatic cancer, tested them in a multi-gene panel for 25 to 29 cancer susceptibility genes, and what they found was about 12.6% of these patients had a pathogenic variant, and irrespective of their age at diagnosis, family history, or history of other cancers. And what you saw was that almost 85% of these patients had a pathogenic variant either in their BRCA, ATM, PALB2, Lynch syndrome genes, or if you're looking at that pie chart, basically in this part of the curves. And what they also showed that the pathogenic variant rate went up to almost 15% if you had more than 2 family members who had a history of having had cancer in the past. Now, was this the only biomarker that could potentially be present in pancreatic cancer? Actually, that's not entirely true. There's a whole potential different plethora of biomarkers that one can see in pancreatic cancers, with almost 24% of these patients with pancreatic cancer having some sort of deficiency in their DDR pathway. Now, why am I also putting this when I'm supposed to be only talking about BRCA mutations? Well, in pancreatic cancers, this becomes exceptionally important, because if you find a target and you're able to appropriately treat that target in a patient with metastatic pancreatic cancer, you may be able to improve survival. And I love this slide that I've put together because it actually compares it to non-small cell lung cancer. You know, patients with non-small cell lung cancer, if you have targeted therapy, that means you're matching therapy, you know that they're going to do very, very well. Look at these curves. This was a study that was presented at ASCO this year, and you can see patients with pancreatic cancers that are matched for their therapy actually are now beginning to do much, much better. A median overall survival of 2.58 years when you're matched, versus if you're not matched, where you have a survival of anywhere between 1 to 1.5 years. Abysmal prognostic outcome in patients with pancreatic cancer, but if you match them, they're now beginning to do well. And you can see on this slide, there's so many different actionable mutations that one can think about in patients with pancreatic cancers. And we know that 17 to 48% of pancreatic cancers will actually harbor these actionable findings. But more importantly, although we don't have prospective randomized clinical trials for all these targets, because this is such a hard to treat tumor with such bad prognostic outcome, NCCN in 2019 has now actually written, it's there in their guideline, which is helping a lot of patients actually get insurance approval, where germline testing is recommended for any patient with confirmed pancreatic cancer, using not only BRCA1, BRCA2 testing, but using a comprehensive gene panel for hereditary syndromes. And they also recommend that tumor somatic gene profiling is now recommended for patients with locally advanced metastatic disease who are candidates for anti-cancer therapy to identify uncommon but actionable mutations. They're actually expanding this cohort. These 2 statements are actually not there for the majority of cancers in NCCN, but they've put it there for pancreatic cancers. And the reason why this is so important, it's a hard to treat tumor, which makes the POLO study that much more important. And the POLO study was a study that actually was recently came out. It was a cohort of patients with metastatic advanced pancreatic cancers who'd responded to chemotherapy in the form of FOLFIRINOX, and they were randomized to either placebo or olaparib if they had a BRCA1, BRCA2 mutation. And you can see a nice separation in the Kaplan-Meier curves. We don't tend to see this. Now, I get a lot of comments whenever I give a talk like this that, look, it's very modest in terms of that separation of the Kaplan-Meier curves, but we don't see this in pancreatic cancers in general. And you can now see a targeted therapy in the maintenance scheme, where you're now beginning to see the separation and an improvement in progression-free survival. And if you look at that subgroup analysis, the majority of patients are now benefiting from maintenance olaparib. So if you put it all together, I've shown you data for the use of PARP inhibitors when you have a germline BRCA1, BRCA2 mutation in breast cancer, in ovarian cancer, in pancreatic cancers. You can see the progression-free survival across the board has improved. You see the majority, the best benefit you're actually seeing in ovarian cancer, but also importantly in breast and pancreatic cancer. But the story doesn't stop here. I think with all that I've told you, we probably now have more questions than we have answers. And I'm going to try and look at some of those questions that have come up as a result of having such spectacular data. One of the first questions that's actually come up, and this is a very long-winded question that's up there, so I'm going to sort of summarize it. How many patients are you actually going to get for germline positive BRCA mutations if you sent those patients based on clinical criteria that's being recommended by NCCN? Can you get more patients if you were to expand that cohort beyond the NCCN clinical guidelines or the ASCO clinical guidelines that are there in terms of who to test for germline testing? So this came out of the Memorial Sloan Kettering group, in which the oncologists sent out about 1,040 patients for germline testing, irrespective of whether they conform to guidelines or not. What the authors showed was that 17.5% of patients had more than one actionable germline pathogenic mutation that was identified. But more importantly, 9.7% of patients that were detected to have some form of germline mutation would not have conformed to the clinical guidelines if the oncologist didn't feel that, you know, I need to send it off irrespective of those clinical guidelines. And as a result, you had an additional 3.7% of patients that could be suitably treated with a particular target. So you're expanding the cohort of patients if you were not to conform to those guidelines, but you have, you know, other characteristics that you wanted to be able to send your patients for germline testing. The second important question that comes up is BRCA1, BRCA2 mutation in fact an agnostic for PARP inhibitors? Well, the simple answer to that question is actually no, but let me give you the data for that. We know that about 4.9% of patients have germline pathogenic or somatic mutation. This comes from a cohort, again, from Memorial, where they tried to actually answer this question. And so in this cohort, about 4.9% of patients had either germline pathogenic or somatic loss of function mutations in the BRCA1, BRCA gene. And you can see that the loss of heterozygosity was higher in BRCA-associated tumors like pancreatic, ovarian, prostate, and breast compared to those that were BRCA-associated. You also saw higher degrees of homologous recombination deficiencies in BRCA-associated tumors compared to non-BRCA-associated tumors. And you also saw that non-BRCA-associated tumors were associated with somatic loss of germline pathogenic allele. So collectively, these data suggest that there's different tumor lineages vary in their phenotypic susceptibility to a BRCA1, BRCA2 defect. Now, in terms of benefit to PARP inhibitors, does it matter if you have a BRCA-associated tumor versus a BRCA non-associated tumor? And I already told you from a preclinical perspective, yes, there are differences. But from a clinical perspective, as a medical oncologist, I now need to know if I'm going to give a PARP inhibitor to a patient who says has lung cancer and has a BRCA1, BRCA2 mutation. Is it going to work? Simple answer, you can see these Kaplan-Meier curves. If you have a BRCA-associated tumor and you're subjected to a PARP inhibitor, you do much better than if you have a BRCA-associated wild-type tumor. But if you have a BRCA non-associated tumor, such as, say, a cholangiocarcinoma or a lung cancer or a kidney cancer, and you try and treat with a PARP inhibitor, no difference between the BRCA mutated and the BRCA wild-type. So overall, mutant BRCA is an indispensable founding agent for some tumors, not all tumors. Particularly, it's more important in patients with pancreatic, prostate, ovarian, and breast cancer. These are the BRCA-associated tumors. Now, the next question is in BRCA-associated tumor, does it matter if you have either a somatic versus a germline mutation in terms of whether you're susceptible to a PARP inhibitor? Well, why is this question important? It's important because we do have these BRCA-associated tumors that have also somatic mutations, and more so when you look at patients with prostate cancer, they have very similar actually somatic and germline mutation incidences. So this is a very, very important question. And when you're looking at susceptibility to PARP inhibitors, you can see from this Kaplan-Meier curve, if you have a BRCA-associated tumor and that patient has either a germline mutation or a somatic mutation, you are going to benefit from a PARP inhibitor versus if you have a BRCA wild-type disease. So it doesn't matter whether you have a somatic or a germline mutation, so long as it's a BRCA-associated disease, you will benefit from a PARP inhibitor. The next question is, in a BRCA-associated tumor, is PARP inhibitor therapy different based on the zygosity of BRCA? And the simple answer to that is no, it doesn't actually matter. And you can see here clinical benefit in the heterozygous versus biallelic BRCA1, BRCA2 mutation. You can see it's the same. And if you substratify based on whether someone has a somatic or a germline mutation, you can see all 4 classes of BRCA mutant patients achieve significantly greater clinical benefit to a PARP inhibitor therapy than do patients with wild type. So it doesn't matter whether based on zygosity whether you're going to respond or not. These patients do respond to a PARP inhibitor. The next question is, can we expand the cohorts of patients that could benefit from PARP inhibitors, where it may not only be about BRCA? So the first question, and I've put an algorithm here because I think there are different strategies that have been adopted to try and expand the cohort of patients that could potentially benefit from a PARP inhibitor. And the first is expanding identification of pathogenic BRCA1, BRCA2 mutations, maybe by including somatic mutations. I've already told you that it actually responds to PARP inhibitors, but more importantly, accurately classifying a VUS. And I love using this example where I've had 3 sisters all coming to the clinic to see me because all 3 sisters have, in fact, cancer. The first sister was patient number 1. She's in her 40s, diagnosed with breast cancer at age 25, treated and recurred at age 45. This was the BRCA VUS that she had. The second sister came to me at age 50 with stage 4 de novo breast cancer. She'd received multiple lines of therapy. I tested her. She had the same BRCA VUS. The third patient was also a sister. She came in her 40s. She had breast cancer at age 30. She came to me in her 40s. I, for some reason, did a CEA value on her. I found it elevated. I did a scan, and she has colon cancer now that was metastatic to her liver. And I tested her, and she has the same BRCA VUS. Now, when these 3 sisters actually came to see me, I didn't know they were sisters until I tested them, and the husband of this patient came and told me, do you know that you're treating the other 2 sisters? And then I compared and I said, my God, they've all got the same BRCA VUS. Would you use a PARP inhibitor in a patient that has a BRCA VUS that is so, for me, this is a pathogenic BRCA mutation. I submitted it to ClinVar and they refused to reclassify it. So I submitted it to my humble MDT and they said, please treat it with a PARP inhibitor. And I treated actually this patient with a PARP inhibitor. I treated that patient with olaparib. She's heavily pretreated. She's now 2 years out CR with a PARP inhibitor with olaparib. So in my mind, this is a pathogenic mutation. It also tends to tell you that you need to be discussing these cases in an MDT because you might find VUSs like this that you can reclassify as a pathogenic mutation. And of course, I've just told you somatic mutations, it does work, PARP inhibitors. This comes from the Ariel 3 trial where you can see that even patients with somatic mutations, if you gave them a PARP inhibitor who have ovarian cancer, it responds. Then we could also be identifying beyond germline BRCA1, BRCA2, a concept known as identification of HRDness. These are tumors without germline BRCA1, BRCA2, but they show homologous recombination deficiencies. Maybe we need to determine an HRD phenotype beyond defects in the BRCA pathway, including patients with other mutations for DNA damage. In the realm of pancreatic cancers, this hasn't been explored yet with PARP inhibitors, but we had some preliminary data actually actually again from Memorial that took patients who weren't treated with PARP inhibitors, but they did reclassify them based on their HRD. And you can see that if you had HRD, irrespective of whether you had a BRCA1 or BRCA2 mutation, you did have better prognostic outcome, especially if you were treated with a platinum. In ovarian cancer, we know there are 3 distinct groups of patients with ovarian cancers: those with germline BRCA mutation or somatic BRCA mutation, those with an HRD defect but BRCA wild type, and then you have the HR proficient group of patients. Why would a patient with ovarian cancer BRCA wild type respond to a PARP inhibitor? Well, in the BRCA wild type, I think there are 2 subcategories: those where you have BRCA wild type HRD defect, that means they have loss of heterozygosity, while those BRCA wild type patients where they don't have loss of heterozygosity and will most likely have variations in their PARP sensitivity. We know that in patients with germline mutations who have ovarian cancer, perhaps only giving, and that comes from SOLO-1 and the PRIMA trial, that only giving a PARP inhibitor is enough. You may not need to add bevacizumab, as the Paolo-1 study has actually shown. So in my opinion, at least when you're testing, it's important to still test for BRCA, because if you're BRCA positive, you may not need to give all these additional therapies that are being explored. But we also know that in patients with ovarian cancer, if they have a BRCA mutation, they have the best PFSs. But if they have HRD BRCA wild type, you have impressive PFSs, but again, slightly less. And if you are HR proficient, you still are benefiting somewhat, but not as much. So sensitivities to your PARP inhibitors will vary based on your HRD status. We also know that HRD and BRCA status will help you choose your therapy, and I've sort of given the summary of the SOLO-1, Paolo-1, and the PRIMA trial and compared it to the GOG-218 study that looked at only bevacizumab without a PARP inhibitor in these patients. And just to summarize, and if you look at these hazard ratios, if you're BRCA mutation positive, PARP inhibitors should be enough. I've just told you that. If you're BRCA wild type, but you're HRD positive, again, look at those impressive hazard ratios when you give a PARP inhibitor versus if you give bevacizumab alone. I think, again, PARP inhibitors should be considered the standard. But if you're HR proficient, you may actually want to consider PARP alone or PARP plus Bev or Bev alone. So it's a very gray zone area, and this is something I think the next speaker is actually going to be expanding on and talking about HRD and the HR proficient subgroup. But why would a PARP inhibitor actually work in an HRP or HR proficient cohort? My explanation, and this is just a snapshot view, you're going to hear about it later on in much more detail. My idea is that there is no perhaps one cutoff score for homologous recombination deficiency. We know all the clinical trials have actually used cutoffs of 42 for that score, but there was a retrospective study, it was called that looked at data from study 19, that was a cohort of ovarian cancer patients treated with olaparib, where they looked at differences if you looked at a score of less than 33 versus less than 42, and what they essentially showed was that if you changed your score, you could have a larger group of patients that in fact benefited from PARP inhibitors. So again, I don't think the story is that simple, and that's going to be clarified later on because you need hours to discuss this. But could this be a method of refining that HR proficient subgroup that could benefit from PARP inhibitors? Now let's expand that realm of HRDness. And remember, I told you one of the other BRCA-associated tumors is prostate cancer. Why didn't I talk about it earlier on when I looked at only germline BRCA1, BRCA2? Because in the realm of prostate, it's not only about BRCA1, BRCA2 testing, but really expanding to other biomarkers. And one of the first studies that actually came out was from Mateo's group. It was published in the New England Journal in 2012, where 49 patients, heavily pretreated prostate cancer patients, were subjected to single agent olaparib, and what they found was that the 7 patients with BRCA2 mutations actually responded to the treatment. But not only them, you can see from this plot over here, there were other biomarkers within that class of patients who had heritable genes that also responded. So what they did was they put it all together and they developed a biomarker signature, and they found that patients who are biomarker positive and treated with olaparib did very well versus those who were biomarker negative, and this was both in terms of progression-free survival and overall survival. So treatment with PARP inhibitor olaparib in patients who had defects in either the germline or somatic DNA repair genes, so not only BRCA1, BRCA2, led to high response rates, improvements in progression-free survival, and improvement in overall survival. And this is what led to the PROfound study. The PROfound study was a phase 3 clinical trial that took patients with prostate cancers who had progressed on abiraterone or enzalutamide, and they were basically castrate-resistant metastatic prostate cancer patients who had some form of defect in their homologous recombination repair gene pathway. And what they did was they randomized these patients to either receiving olaparib or receiving enzalutamide or abiraterone. And you can see in terms of progression-free survival in the cohort of patients who had a BRCA1, BRCA2 or ATM mutation, again they had a very nice separation in the Kaplan-Meier curves, improvement in progression-free survival. But it was not only restricted to this. In an exploratory analysis, they looked at the PFS across the HRR genes alterations. They found the biggest benefit was actually amongst patients with BRCA2 mutations, another big benefit in patients with RAD51 mutations, not so much benefit in patients with BRCA1 mutations, but again, this was exploratory. And what I personally believe in prostate cancer patients, we need to be looking at all these genes in the HRR pathway, not only BRCA1, BRCA2. What about identification of PARPness? What is PARPness? Well, PARPness are cancers that lack mutations in the HRR pathway and do not typically display an HRDness, but they still have some sensitivity to PARP inhibitors. Now, why did I put this in? This is just for completeness sake. It doesn't actually pertain to testing anyone. But the reason why I put this in was because it does pertain to some malignancies like small cell lung cancer, where you can actually target with a PARP inhibitor, although they don't have a defect in their DDR pathway. Why? Because they are actually very, very dependent on an intact stable DDR pathway. And what you see in small cell lung cancer patients, they actually have loss of RB1 and they have loss of TP53, which can sometimes cause instability. And when that instability happens, by adding a PARP inhibitor, they may actually become sensitive to that pathway. And you can see this was a very small trial that looked at a combination of olaparib and temozolomide in relapsed small cell lung cancer. And these were patients who were heavily pretreated, overall response rate of 41% and overall survival of 8.5 months. And you can see there was no difference in overall survival by platinum sensitivity. So it didn't really matter if there were mutations in that HRR pathway or not. So even tumor lacking HRDness could be potential candidates for PARP inhibitors, but this is just something that I put there as food for thought, but something that we need to think about. I think identifying resistant mechanisms to PARP inhibitors is just as important as identifying patients who will be sensitive to PARP inhibitors. This becomes particularly true in patients with ovarian cancers and patients with prostate cancers, pancreatic cancers, where you may think about re-challenging these patients with PARP inhibitors in the future, or even after they've been treated with a platinum, should they be even treated with a PARP inhibitor because they may have already developed a resistance mechanism to that PARP inhibitor. We have several mechanisms that are being investigated for PARP inhibitors, including drug avoidance by pumping these drugs out of the cell through a membrane protein, restoration of the fork protection by inactivation of nuclease enzymes, remutating the original BRCA mutation to restore the functions of the BRCA proteins, and of course restoration of homologous recombination repair. Now, this was just a case study that came out a couple of years ago that I think very nicely illustrates the BRCA2 reversion mutation that's associated with an acquired resistance. This is a patient with breast cancer that was treated with multiple lines of therapy, and then she was found on a tissue biopsy to actually have a BRCA2 mutation, and she was then eventually treated with olaparib over here. She had about a 6-month median progression-free survival, at which time she progressed, and they added olaparib to chemotherapy, and this patient continued to progress, and that's where they tested and they found that she had in fact developed a BRCA reversion mutation. I also think in the realm of ovarian cancer, this becomes more important as we use maintenance therapy for PARP inhibitors in ovarian cancers. Once you've completed your maintenance therapy, if that patient recurs, can you re-challenge with a PARP inhibitor? Perhaps you need to test those patients for BRCA reversion mutations, because if they have a BRCA reversion mutation, giving a PARP inhibitor is not going to work in that particular patient. So again, it's going to become something that we're going to need to test in the future. And finally, a snapshot view of what I think the future is going to be. It's going to be combination strategies with BRCA, with PARP inhibitors, because we know not all patients with BRCA1 mutant cancers will respond to PARP inhibitors. We know that drug resistance will eventually develop, and somehow we need to delay that. We want to maybe increase the response rates and those durability of responses. So we're going to look at PARP inhibitors with molecularly targeted therapies like BEV, like MEK inhibitors, PI3 kinase inhibitors. In fact, we've had some nice preliminary data looking at olaparib and alpelisib in patients with breast cancer, wild-type BRCA, where they've seen some nice responses, even better than when you give alpelisib with endocrine therapy. We've also seen in patients with prostate cancer the combination of olaparib plus abiraterone, and we've seen some nice data looking at, irrespective of whether you're selecting them for their BRCA status or not, there seems to be some nice responses there. We're also going to look at PARP inhibitors with other DDR inhibitors, so it's going to be important for us to also look at those and test those targets in the future. And of course, now this is upcoming, I won't berate the point, we're going to look more and more at the combination of PARP inhibitors and immune checkpoint inhibitors. It's literally becoming even more important, because patients with BRCA1 and BRCA2 mutations actually have, most of them, high tumor mutational burdens, where you're going to really think about using those immune checkpoint inhibitors where you know you're going to have maybe a higher response rate. So my conclusion slide, there is no doubt that BRCA is now an important marker to allow for identification of patients at high risk of developing malignancies. That's your screening cohort. But what about for the medical oncologist? We now know that BRCA is an established biomarker that identifies patients with BRCA-associated tumors that will likely respond to PARP inhibitors. In my opinion, all patients with BRCA-associated tumors should be tested for BRCA, and my personal opinion, it shouldn't only be BRCA. I think you need to do the expanded panel to look at all those genes, because we are now going to be using PARP inhibitors beyond BRCA. For the present time, BRCA mutation cannot be considered as an agnostic marker. I showed you the data for that. And our current focus should be to expand cohorts of patients with BRCA-associated tumors who could benefit from a PARP inhibitor, including identification of HRDness, and perhaps also doing those combination strategies that I was talking about. Going forward, it will be important to identify resistant mechanisms to PARP inhibitors and identify methods to overcome them. Thank you very much.
Questions to the end, but actually Dr. Shaheenah has to leave because she has a flight to catch. So are there any questions for her talk before she leaves? So I have a question actually about this is interesting family with the three sisters with the VUS, and I agree with you that if you have 3 affected family members and who actually all are affected and they actually carry the same variant, it does make it a strong case to reclassify. So did you actually communicate with the lab? Because sometimes through the lab it might be a, okay, so
still refuse to reclassify it, and I think it's just they've got their own mechanism by which they reclassify. But really the point that I was trying to make, like you said, that if it's running in a family and all of them have cancers, you really need to think about the fact that they're pathogenic. That's number one, and that PARP inhibitors could work. But I also think that, you know, it also depends on the test that you're doing, because some tests actually classify a high rate of VUSs and some actually classify low rate. I think it also depends on the type. And I'm not a technical person for that, but I think being in Asia, now we're here in ESMO Asia, being in Asia, all the data is actually coming from a Caucasian cohort. We don't have a lot of data in our part of the world to accurately classify this data, including the Middle Eastern patients. And I've always advocated that perhaps we need to pool our data together and come up with our own, you know, classifications, because I think we're very different from the Caucasian cohort. But I'd love to hear your thoughts on that.
Yeah, so I agree with you that it all depends on the population. But as that population gets tested more, then you'll find that the VUS rate will go down. Okay, so thank you very much. So thank you. Oh, she has a question. Yeah.
So in early breast cancer, when you after you did mastectomy, and then you found that the patient has BRCA positive, germline BRCA positive, are you giving the adjuvant of the BRCA?
So the Olympiad and the EMBRACA trials were only for patients with metastatic disease, not for early stage disease. However, there is currently an ongoing trial right now that's looking at, after you've treated your patient appropriately with chemotherapy, surgery, radiation therapy, whatever is the standard for that particular patient, to maintain them on a PARP inhibitor. But that's still in clinical trial. I wouldn't advocate it outside the realms of a clinical trial right now.
Thank you very much. So thank you, Shaheenah.